Nuoširdžiai sveikinu jūs šios dienos pokalbėje. Šio pokalbio esmę pateiksiu maždaug per pirmasis 4-5 minutės, o paskui, jeigu norėsite, galite žiūrėti viską. Tai pagrįsta šiuo klausimu. Jį pateikė Sara. Džonai, prašau, ar galėtumėte peržiūrėti šį straipsnį iš Izraelio nacionalinių naujienų, kuriame rašoma, kad Miokardito rizika po mRNA ir COVID vakcinos yra maždaug 133 kartus didesnė už foninę riziką. Ar tai tiesa? Ir jei tai tiesa, kodėl apie tai nekalbama sisteminėje žiniasklaidoje? Pirmiausia, reikia atsakyti į paskutinį klausimą. Nežinau, kodėl sisteminė žiniasklaida apie šios dalykus nepraneša dažniau nei praneša. Manau, tai yra teisėta informuotų komentarų dalis. Taigi, aš nežinau atsakymą į šį klausimą, turėtumėte paklausti įvairių sisteminių žiniasklaidos priemonių generalinių direktorių ir ten atsakingų žmonių. Tiesiog, kad patikslinti čia pateiktą klausimą. Tai yra naujas tyrimas ir jis tikrai sako, kad 133 kartus blogiau susirgti miokarditų po COVID vakcinacijos. Ir kad atsakyti į šį klausimą, mes turime tiesiog vadovautis būtent tuo, ką sako įrodymai. Mes turime eiti į faktinį tyrimą čia ir iš kur tai atsirado. Taigi, tai yra tyrimas, iš kurio iš tikrųjų tai kilo. Jis paskelbtas Amerikos medicinos asociacijos žurnale JAMA, kurį galite nemokamai atsisiųsti PDF formatu, tai žinoma yra labai dosnu. Ir visa tai yra ten. Tiesą sakant, tai nėra labai lengva skaityti. Dėl to aš jums pateiksiu tarsi greitą šio dalyko apžvalgą, santrauką, o jūs galėsite nuspręsti, ar norite klausytis likusios dalies ar ne. Ar yra 133 kartus didesnė rizika? Iš tikrųjų, ji tikriausiai yra daug didesnė. Bet, ką mes žinome iš duomenų, bent jau mano skaičiavimai, tai 84 kartus didesnė rizika. Didelės rizikos kategorijoje esančių jaunų vyrų ir paauglių. Kodėl aš sakau, kad tai iš tikrųjų 84 kartus didesnė rizika, remintis duomenimis, bet sakau, kad tai tikriausiai daugiau nei 133 kartus didesnė rizika. Kitaip tariant, tai yra nepakankamas rizikos įvertinimas. Na tai labai griežti miokardito diagnozavimo kriterijai ir iš tikrųjų perikardito. Gana griežti kriterijai. Taigi galima įsivaizduoti, kad kai kurie žmonės turi miokardo uždegimą, todėl pagal apibrėžimą tai yra miokarditas, gali neatitikti kriterijų, kurie būtini ir tai būtų teisinga kai kuriais atvejais. Žinoma, daugeliu atveju tiesiog nepranešama apie šį įvykį. Kiek tokių atvejų yra? Mes neturime jokio supratimo. Visa tai pagrįsta VIH duomenimis, pranešimo apie nepageidavimus vakcinų reiškinius sistema Jungtinėse valstijose. Aš tai peržiūrėjau ir ten parašyta, kad VIH ataskaitą gali užpildyti bet kas. Ar tikrai? Kad tai padarytum, turi būti gana specializuotas gydytojas. Turiu omeny, kad turėjau apie tai pagalvoti. Ir jau anksčiau jums rodžiau, kodėl tai sudėtinga. Taigi, galime daryti išvadą, kad yra padidėjusi rizika miokardito ir perikardito po mRNA vakcinų. Galima teigti, kad neabejotinai. Ar galima teigti, kad tai sukėlė vakcina? Techniniu požiūriu dokumente to neteigiama. Jame sakoma, kad padidėja rizika po vakcinos. Taigi, jūs patys turėsite nuspręsti, ar yra priežastinis ryšys ar ne. Straipsnyje neteigiama, kad yra priežastinis ryšys. Jame tik teigiama, kad rizika padidėja, kas yra ryškiai taip. Taigi, jei norite toliau žiūrėti, žiūrėkite, gana įdomus dokumentas, bet toliau išversti nebuvo galimybės. Bet yra automatiškai sugeneruoti angliški subtitrai, jei žiūrite YouTube kanale.
Pretty interesting paper. Now, myocarditis cases reported after that, that's the name of the paper there. US data from the 20th of December to August 2021. So, there's a good few months of data there. That's good. Paper published just on the 25th of January. Now, I've just put this list of people in here so you can see where these people are working. This is a very prestigious source. So a lot of people work for the CDC, School of Medicine and Moore University, Children's Healthcare of Atlanta, etc. Pretty prestigious institutions and a long list of authors. So this paper carries quite a lot of credibility. This is the actual reference that JAMA like you to cite, so I've done so. That's their actual reference. Now, this is important because vaccinations against COVID-19 provide clear public health benefits, according to the paper. But vaccination also carries potential risks. So I think both fairly obviously true statements there to kick off. The risk and outcomes of myocarditis after COVID-19 vaccination are unclear, according to this paper. So they're actually saying that it's still unclear. That's why this needs clarified, which is, of course, is what they're attempting to carry out with this paper. Where am I? There we are. To describe reports of myocarditis and the reporting rates after mRNA-based COVID-19 vaccines in the United States. So that's what this is about. Now, it's a descriptive study. Reports from myocarditis to the Vaccine Adverse Events Reporting System, VERA. So it depends on this reporting, and it's a passive system. So if this complication comes up, or any complication comes up from the vaccine, people can decide to fill out this VERAS form or not. But as I'll show you, it's really quite a complicated form. And I know very often when drug complications are come across in the UK, it's actually quite a big job to report it. So sometimes it's just simply not done. So really, these VERAS returns are the minimum amount, and the real number could be much higher. But of course, I can't say that definitively. We don't know. We don't know how often these forms aren't filled out. We don't know how often they are filled out. After mRNA-based vaccine, so that's what this is about. Now, let's before we look at some interesting graphics, let's look at this. So it's between those dates, 20th December, 21st of August, in 192 million people older than the age of 12. But of course, we notice that of this 192 million, which is the whole number of people probably been vaccinated in this time period, many of these are much older than the age range in which myocarditis is likely to occur. So that figure, you could argue, is well, it is correct, but it's also remember, it's the younger demographic that's at risk of this. It's virtually unheard of at my age. This is typically people under 30 that are affected by this. So here we have some of the data here. So this is vaccination with BNT162b2, which of course is the Pfizer vaccine. So up and down here we've got reported cases of myocarditis after vaccination with Pfizer. Age at onset of myocarditis. So these are years. So for example, the highest rate here is people that are 16 years of age. And that was the number of cases with the Pfizer vaccine. Until we get to 40 years of age, when 39, 40, when there's actually very few cases, and they don't even bother putting the 50s and 60s and 70s and 80s because it is so uncommon, or virtually unheard of in those older age groups. So this is so important because we're dealing with young people here. And this is the number. This is the number for all young people. I'm pretty sure. Yeah, I think that's the number for all young people there. So, and this is after the Moderna vaccine. Now, if we just look at the scales here, so that was like 40, 60, 80. This is 20, 40, 60. We see many less cases with the Moderna vaccine. So more cases with the Pfizer vaccine. And again, age in years across there. Now, this is vaccination with Pfizer, and this is reported cases of myocarditis after vaccination, and this is days after. Now, this shows that you get a few cases on the first day, but most cases are occurring on the second day. Some on the some on the first day after, most on the second day after, third day after. So most of these cases are occurring, the vast majority in the first few days, but virtually all in the first 10 days. So this is shortly after the vaccine dose. More common, of course, after the second dose. And again, with the figures here for first of all, we notice that the numbers here. That's 200 line there. With the Moderna, that's the 80 line there. So it's less common with Moderna. But again, similar time after vaccination. Most common in the first few days after the vaccine has been given. Most common with the after the second dose. Now, during the analytic period, Pfizer vaccine 12 years and older, mRNA vaccines were being given to the Pfizer vaccines were being given to people 12 and older. The Moderna vaccines at this time were only being given to people 18 years and older. So during this time period, that is who were being vaccinated. So no one was getting no one between the ages of 12 and 18 were getting the Moderna vaccine during this time period. So that's what they were exposed to, those vaccines. Main outcomes and measures. Expected rates of myocarditis by age and sex were calculated using the 2017 to 2019 data, and that's how we get that number. So the expected number of cases of myocarditis was in that age group was taken before the pandemic, 2017 to 2019, compared to this 2021 time period when this data was actually collected. For people younger than 30 years of age, medical records reviews or clinicians' interviews were conducted to describe clinical presentations, diagnosis, etc. But of course, these were not always available. The full clinical details were not always available. They were in most cases, but not always available. So the result, now remember, amongst this 192 million people vaccinated, 354 million doses of vaccine, but most of these vaccines, of course, were given to people over the age of 30. So it's a bit misleading, that. So if we looked at the number of vaccinated people in that age group, it will probably be better, because, as we say, the older people are essentially at no risk of this complication. So a bit disappointing they didn't break that number down further, really. This would tend to make the cases look rarer than they are, because these are the cases for the whole population, not that particular demographic, which was unfortunate that they chose to express it like that. 1,991 reports of myocarditis. 1,626 met the criteria. Now, how many cases of myocarditis were there? We don't know. All we know is that many were reported on the VERAS system. The actual number of cases we don't know. Of those with myocarditis, median age 21, interquartile range, in other words, 50% fell between the ages of 16 and 31. So to be fair, 25% of cases there are over the age of 31. So it's not unheard of in slightly older age groups. Median time to symptom onset, as we said, was pretty quick, 2 days. Males, 82% of cases. Now, it's a pity, well, you could argue it's a pity that the adenovirus vector vaccines, which are associated with a much, much lower risk of myocarditis, were never rolled out in the States, because it could be, when you actually add up the relative risk, that it's safer to give the adenovirus vector vaccines, like the Oxford vaccine, to young men, because the young men are those ones most at risk, 82% of myocarditis cases, meaning that the other 18%, of course, were in females. So the vast majority of cases in young men, which of course is exactly what we don't want. Now, reporting rates for myocarditis. Within 7 days after COVID-19 vaccination, exceeded the expected rates of myocarditis across multiple age and sex strata. So, in other words, in any age group, there was more cases of myocarditis than would be expected, and in both sexes, there was an increased incidence. So, even in young women, there was an increased incidence compared to what had been expected in the years 2017 and 2018, or whatever the comparator years were. Rates of myocarditis were highest after the second dose of vaccine, which we've known for a long time. Adolescent males 12 to 15, 70.7 million doses of the vaccine given, and 70.7 cases of myocarditis per million cases of vaccine given. So nearly 71 cases per million vaccine given. And I've worked that out as one case in 14,144. But again, many of the people that were vaccinated were much older. And it's not clear, the paper's actually not clear whether it's just comparing within its demographic or for everyone. It's not really clear on that. Males aged 16 to 17, 105.9 cases per million doses. That's one case for 9,442. But if we just look at the demographic, I think that would be a fair bit higher, is my understanding, as my reading of this paper. Males 18 to 24, 52.4 per million doses. That's one case in 19,000. And 56.3. Actually, in that particular age group, it's a bit confusing there. Let's go by the graphic. That is what it says in the paper, but the graphic indicates that that's not correct, so I'm not quite sure if that's just a fault in the way the paper's written. Anyway, that works out at one case in 17,000 and a bit. Now, myocarditis under 30. 826 cases who had detailed clinical information available. As we said, quite a few didn't have detailed clinical information. And again, we'll see the gaps in the data here become obvious. 792 over 809, 98% had elevated troponins. Now, troponins are associated in the heart. There's contractile fibres that cause the heart to contract, so it contracts and then relaxes. And troponins are part of these contractile fibres. And if a heart cell is damaged, if a myocyte is damaged, these components of the contractile fibres that are supposed to be kept inside the cell get out into the blood, and it's a sign of cardiac cell damage, basically. So it means that most of them had damage to their myocytes, their myocardial cells. 72% abnormal electrocardiogram results. And again, there are criteria for this. So the electrocardiogram is just the way the heart is beating. You probably, in the UK we call it ECG, in the States they call it EKG. So you have a P like that, then you have a QRS complex like that, and then you have a T wave like that. And they're equal, that they represent the electrical activity going on in parts of the heart. So that is the contraction of the top chambers of the heart, atrial myocardial contraction. This one here, the QRS, so that's P, Q, R, S is the contraction of the QRS complex is the contraction of the ventricles, the main pumping chambers, and the T wave is the electrical activity of the main pumping chambers going back to normal. So a normal rhythm's got a PQRST roughly in the right order, and the rate is exactly in the right order, and the rate is between 60 and 100 for a sinus rhythm. So that is a normal sinus rhythm. So there's an abnormality of this. 72% had cardiac magnetic resonance imaging results. So 72% had MRIs, and the good thing about these modern cardiac MRIs is you can actually see the heart contracting. So it gives you kinetic information about the contractility of the heart, which of course can be impeded if there's inflammation of the heart muscle. Hospital data, 96% were hospitalised, so most of these patients were hospitalised, of the ones that were recognised, of course. 87% had resolution of symptoms by discharge from hospital, which I suppose is good. But of course that means 13% didn't. So, it's kind of easy to put this in a particular way. 13% didn't. And most common treatment was non-steroidal anti-inflammatory drugs, such as the most simple one that everyone knows about, of course, is aspirin. More common ones these days are ibuprofen in the UK, naproxen, diclofenac. They've probably got different names in the States, but these are the non-steroidal anti-inflammatory drugs, which are very good analgesics. And it doesn't mention this, but paracetamol or acetaminophen is also good for pericardial pain. Surprisingly, I used to treat patients with pericardial pain, and they often responded better to paracetamol, that's acetaminophen or Tylenol, than they did to morphine. Strange, but absolutely true. Anyway, these were the figures for 16 to 17-year-olds. Now, I know you can't see this, but that's the incidence after the first vaccine, which was 7.26. That's the incidence after the second vaccine, which was 105. That gives a total of 113.12 cases, and normally you would expect 1.34 in the same time period. The expected is 1.34. So 1.34 divided into 113.2, I get 84 times more likely. But as we say, the real number's probably way higher than that. Now, I don't know how much detail to go into today, but this is the supplement that we get. So I'm just going to mention this a little bit because there are some causes for concern here. So presence of one or more new worsening of the following clinical symptoms: chest pain, pressure or discomfort, shortness of breath, difficulty breathing, pain with breathing, feeling your heart beat inside your chest, palpitations, syncope is fainting. But as well as that, you need to have a histopathological confirmation. Now, this would only be detected on post-mortem because I really can't imagine they're doing cardiac biopsies. So histopathology, of course, is where you look at the heart under the microscope or some of the tissues under the microscope. And the idea that you would do that in a living person is, I've never seen it done. Maybe some centres do it. So if you're a clinician working in the States and you do cardiac biopsies on living patients, then do let me know. But I will be surprised. So, but if they didn't have that, which they probably wouldn't, then they would need an MRI. So it's getting quite difficult to get to be a confirmed case. So you have to have the presence of one or more of these, fair enough. But then you have to have that, which will probably never happen, or you have to have an MRI, which can be difficult to obtain. So you had to have a cardiac magnetic resonance imaging finding consistent with myocarditis and troponins. So they're kind of making it a little difficult and no other identifiable causes. To be a probable cause, you need those same things as well, probable case rather. So those same clinical criteria. And you also need troponin levels above the upper limit, fair enough, an abnormal ECG, or rhythm consistent with myocarditis, abnormal cardiac function or wall motion, as we said with MRI or sometimes ultrasound scan, or MRI findings. So they're making it quite difficult and to eliminate cases. So you could say they're being exacting, but that could mean that some people this could mean that some people with, say, mildly inflamed myocardiums aren't being put forward as a probable or confirmed case. It could mean that. And again, quite difficult to die. So ST segment or T. I'm not going to go into these, but you can see there's extra criteria there. So ST segment or T wave abnormalities. I mean, I'll just explain the first one, the ST. So as we said, the normal rhythm is the P QRS and the T wave. So remember that's P Q RST. So an ST abnormality will be an abnormality between there and there. So what you might have, for example, is you'd have a P, a QRS, and then something like ST elevation like that before the T wave. So that would be an abnormality of S. So the S, that would be the S there, and the T there. So there would be an abnormality in those bits. So instead of going down like that, it might just go like that. So these are fairly specialised things, and I'm not going to go into them. I'm not going to go into them in detail. It does mean it's fairly the specific criteria. It's not any change in the ECG. In other words, there's these specific criteria. Now, reports on the VERAS system. It says this on the VERAS website here. The vaccine adverse events reporting system is a passive reporting system, meaning it relies on individuals to send in reports of their experiences. Anyone can submit a report to VERAS, including parents and patients. So anyone can do it, or can they? Because let me just show you the form that needs to be filled out. Now, here we have part of the form here. Part of the form. So you would have to decide whether there's any anaphylaxis, coagulopathy, COVID-19, death, Guillain-Barré syndrome, Kawasaki disease, multisystem inflammatory system in adults, multisystem inflammatory system in children, myocardial infarction, myopericarditis, narcolepsy, pregnancy, seizure, stroke, transverse myelitis, or other. Now, this is not a quiz, but how many members of the public would know what the heck that was talking about? I mean, you might know what anaphylaxis is, the severe allergic reaction. You might not, but why should you know that that relates to abnormal clotting of the blood? You wouldn't have a clue. GBS, how do we even know it stands for Guillain-Barré syndrome, let alone what it is? Kawasaki disease, an inflammatory disease, myocardial infarction, blocking off of part of the heart muscle, myopericarditis, inflammation of the myocardium and inflammation of the pericardium and myocardium, narcolepsy, you're always falling asleep, seizures, fitting, stroke is a cerebrovascular accident, transverse myelitis, it is a transverse lesion across the spinal cord. So if that's a spinal cord running up and down there, transverse myelitis would be a lesion that goes across that. But I mean, that's not, how could a member of the public fill that out? They simply wouldn't have the, it's like me doing a flight check before takeoff on an aeroplane, whether the flaps are right, I don't have a clue. Also, you're asked, they'd asked you to identify other infections. So the member of the public, it would appear, is expected to know whether the infection was adenovirus, Coxsackie virus. I mean, how could you know any of this stuff? It's all specialised stuff. Another part asks you to say if there's any rheumatoid arthritis, scleroderma, systemic lupus erythematosus, Sir-John syndrome, or other inflammatory diseases. I mean, how can a member of the public do that? Also, another part of the question here is ST elevation abnormalities, T-wave abnormalities, PR depression, atrial, supraventricular or ventricular arrhythmias, conduction delays or block. I mean, AV, that stands for atrioventricular block, first degree. Who knows, unless you're a cardiac nurse or a cardiologist, you're not going to know these things. Try these out on an average GP and see if you can remember them. You probably won't be able to, unless you've done cardiology recently. Or another part, decreased left ventricular function, pericardial effusion. What is an effusion? Well, an effusion is a collection of fluid, but how would you know that? Ejection fraction, all these things, how would you know them? So how on earth a member of the public could fill out one of these forms? Well, they couldn't. I don't see how they could. I just don't get it. So you are relying on the patient's doctors to fill it out, or specialist nurses who have knowledge of these things. But the idea that I actually struggled when I read that. It actually said that anyone can submit a report to VRAS, including parents and patients. It would be interesting to know what proportion of these forms were sent in by parents and patients in the individuals, because unless they were clinicians themselves or some sort of medical scientists, I don't see how they possibly could. Correct me if I'm wrong, but I don't get that bit. So there we go. Now, the last question is, has there been any previous myocarditis, pericarditis from other vaccines? And the answer to that is yes. Previous vaccination of myocarditis, only smallpox vaccine is the only one though. American military personnel, but that wasn't 7 to 12 days after vaccination. So this pericarditis, myocarditis does seem to be unique to the mRNA vaccines. And of course, I'm reminded that we talked to one of the leading scientists in Denmark about this, Professor Niels Høiby, on a video on this channel. And he compared the incidence of myocarditis in Denmark to Norway. And of course, in Denmark, they are aspirating before injecting. So they stick the needle in and they draw back to make sure they're not in a vessel. And if the blood comes out and they think they're in a vessel, they're not going to give it. So that's in Denmark, whereas in Norway, they don't bother. And he found that there was 3 times more cases of pericarditis in Norway where they don't aspirate, as opposed to Denmark where they do aspirate. Therefore, everyone should be, in my view, everyone should be aspirating and eliminate that variable, but that's not being done. Okay, a bit complicated today, so hope you followed that. So we can say that there's more myocarditis. It's increased after vaccination, and the 133 figure times 133 figure we don't have data for. The times 84 figure we do in that particular age group, but for the reasons I've mentioned, it's probably more than 133 times. So what I would appeal is for this to be covered more on mainstream media so that people can make informed decisions. That's what this is about, giving information to make informed decisions. And I'm going to leave it there. Okay, thank you for watching.